Okay. As long as you guys can see my screen, I put up the agenda for today. We are on, I don't know which iteration of our change management regional working group for ambulatory. Today we're planning to talk about medication reconciliation. So please ask questions while I walk through this or work through this. Happy to answer anything that you guys have on it. So without further ado, I am logged in as a physician, so just to share that context with you guys. Obviously landing on our home page here, so Message Center on the left side, Ambulatory Organizer on the right, would be able to see the list of patient appointments for any given resource, whether that be an individual physician or a specific clinic where a patient is scheduled for the day. So I have my test patient here. They are already checked in, and I'm going to open up their chart. This is going to bring me directly to our ambulatory workflow page or our provider view. We can look at this from a couple different aspects, and where I usually start from a medication reconciliation standpoint is with home medications. So we do have a home medications component on the outpatient or ambulatory workflow page, which is going to show the patient's documented home medications as well as any active prescriptions that they have. So big distinction between those two. And I'll try to explain it the best I can, but please let me know if clarification is needed. These two medications are documented home meds, which means they could be a medication that the patient is taking over the counter or a patient is taking from a non-Lumio provider that we have record of. So, meaning it was not prescribed in the Lumio system or was not prescribed by a Lumio provider in the Lumio record, but doesn't mean that the patient isn't taking it. It just means it's a documented home med instead of a prescription. On the other side of that, an actual prescription order that was written from the Lumio system is going to show with this icon, the prescription icon. It's going to show you all the details of that prescription, as well as the responsible provider or the person who prescribed that. So this was a test account, but usually that would say the physician's name of who prescribed that medication and ultimately who is responsible for it. So that's kind of the differentiation on our home medications. That said, home medications and medication reconciliation go hand in hand because of our med history. So I will point that out in our med history or in our home medications component. We keep the status of our med history as well as our outpatient medication reconciliation, and these are going to reset per encounter or per visit. So each time a patient has a new visit, either with a new provider or on a net new encounter, those are going to reset so I can see that my meds history is incomplete. If I click on that, and just to note, like I said, I'm logged in as the provider, but it could be, or I'm logged in as a physician. It could also be a nurse or anyone else that can take a med history. So here we can see those same medications, and there I get the status of documented versus prescribed on my documented home meds versus that prescription order. And there's a few things that I can do here. We can say that we are unable to obtain this information because either the patient doesn't know or we do not know. We can also use last compliance, which I will get into last compliance. And we can actually, in the bottom right here, we can say we want to leave the med history incomplete and finish later. So those are some options. And if I do go through any of the existing meds, so if I look at my lisinopril here, we can actually add or modify compliance. Compliance means what is the status of the patient taking that drug? So are they still taking as prescribed? Are they no longer taking this drug? Are they taking it but not exactly as prescribed? Or are we unable to obtain or investigating that information? So if the patient is still taking as prescribed, if the last day they took it was yesterday, we can document that information. And then we can go through and add or modify the compliance for any of the other drugs as well. If the patient is no longer taking, we can say not taking. And then on our prescription, Add or modify compliance. We'll say still taking as prescribed here as well. Last date they took it was maybe last Friday. So that puts in the compliance for the medications that the patient is already on. We can add compliance comments here as well if we want to have that, and that will show up in my compliance comments. The other thing that is part of a med history is if the patient is taking anything else. So if the patient is actively taking any other medications that are not listed here, so maybe they were recently put on insulin, we could document that. I can grab from the search box one that already has an order sentence, which means the order details here are already filled out. If anything needs to be changed within those order details, I can still change it, whether that be my dose, route, frequency, etc. But essentially what we're trying to do here is get that best possible meds history, so as much information as we can. And if we need to fill in the compliance, we can do that as well. Patient last took this, we'll say today. And that is really it for the medication history. If I have this completed, and this is exactly what I want for this patient, I would hit the document history button. If it is not quite complete, we can check that leave med history incomplete and finish later. That way we have not marked this as done. I'm going to pause right there for any questions that you all have about the med history. Have we all seen this, been trained on this, already talked about it? Just go ahead.
I have a job aid from the region around taking like best possible medication history. And there's just a part in compliance that I wasn't sure about as you were going through compliance.
Okay, I can reopen that for one of these.
It says compliance, status of medication, unable to obtain, and then it says under not taking, it says do not document medications that the patient is no longer taking. The physicians may not notice and may unintentionally restart the medication during the admission medication reconciliation process.
I think that's fair. So we can use the compliance status of not taking. Realistically, if we wanted to, I'm going to reset this one. If the patient is no longer taking this, we would probably want to say cancel discontinue, because that's going to take it off of their documented home meds or off of their medication list.
Yeah.
So we can just simply remove it rather than update the compliance as not taking. Now, I guess that's kind of a slippery slope or a gray area, because if it's a prescription that the physician or that we know the physician wants the patient to be taking, we would probably want to flag it as not taking rather than just discontinue the prescription.
I agree.
So I think that's probably a case by case basis. Now, something like a multivitamin, like I'm using in this example, maybe not harmful, but if it is insulin or oral chemo or something of that nature that we know the patient should be taking and isn't, I think the best way to flag it is to say update that compliance as not taking, or even not taking as prescribed.
Right. Okay. Just the wording is a bit convoluted, I think, in the job aid. Okay, but that totally makes sense.
Yeah, so we can just as easily, when we're updating this medication history, and I should have at least pointed that out, we can discontinue or remove anything, and that's going to take that off. So once we hit that document history button, everything here will be updated. My multivitamin is no longer showing. Our compliance is now updated, and we also have our status showing that green check mark that we have completed our med history. Other home meds / med history questions from the group?
I have another one around, but this is more for nursing. So I know you're in the physician category, but I can park that if you.
No, 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 go for it because I can log in as the nurse.
So this is also related to the job aid. It said it's modifying or deleting a previously prescribed med. So the process it's saying is that prescriptions can't be modified by a nurse, of course. These are orders, but if the patient is still taking the medication, but the details of the prescription have changed since it was last prescribed, dose, frequency, etc., right-click on the med and select complete, and then re-enter the med as a documented medication using the add button. So what it's really saying is like you're completing a prescription and then adding a new documented medication.
So what is the intent to say that we actually want the prescription to be modified and the physician is directing the patient to take it differently, or the patient just is taking it differently?
The patient is just is.
I would classify that more under compliance unless the physician has actually directed or is okay with you changing the prescription or okay with the nurse changing the prescription.
Okay.
How are you perceiving that?
I feel like it's a lots of room for error and it's a bit risky. So I
Let
just
me
didn't
see.
know, like, because we're actually like deleting actually the prescription. And then they're just documenting a new dose and frequency, but when we tested it, the prescription just disappeared.
Yeah, so and that would be the issue with completing it. So if I go back to my meds history here, which I can do again on this same encounter, even though this is going to show that it was last documented by, and this is a good thing to point out, last documented on date and time by whom. So there was my physician login. Um, as a nurse, you certainly have the ability to complete.
Yep.
Um, I think if depending on the scenario, if the physician is saying we want the patient to now take it in this way, I think I would modify without resending, put in the physician's name who is directing us to change the prescription, and then use either, verbal with readback so that they can get a cosign, or if this is under a medical directive or a policy slash clinical scope, that would be fine. I think if it's something that I just talked about, I would use that um, verbal with readback so that the cosign does go back to that physician. And then if we wanted to change this from 2 tabs to 1 or some other detail, we could
Okay.
do that and modify the prescription without technically resending it or reprinting it because we don't need the patient to go get a refill.
Okay. That's like modifying it as per the physician's orders. This
Correct.
is modifying it as per the patient is saying, oh no, I'm not taking 2 of those right now, I'm taking 3, you know? So that you would recommend putting it under compliance and then the physician can follow up with the patient.
Yeah, I think that's what I would do. So I would
Okay.
say if I'm not actually trying to modify the prescription, so let me reset this. If we're just the patient is reporting that, hey, I'm still taking this, and then they're saying what I'm actually taking it this way, taking 3 tabs
Yeah. Okay. I agree with that.
per dose. And then physician would still have visibility to that.
Okay.
Yeah, so it really just depends on what you're trying to accomplish. Are we intentionally modifying, or was this I want to note that the patient is no longer taking that prescription as it was written?
Got it. Okay. Perfect. Thank you.
No problem. Good question. Yeah, and part of the reason I wanted to give the context of doing the med history as a physician and or the nurse is you both have the same capabilities when it comes to the med history. Um, Obviously, physician has the ability to prescribe new drugs without sending for cosign. Nurse can still enter that prescription. It's just going to require them to input that ordering physician. This is still the nurse. don't believe. Let me jump back to my actual physician login. Okay, we're under the physician again. Once that best possible meds history is completed, we would be able to then complete our outpatient medication reconciliation. When I click that, I'm going to be brought to this screen here, which gives me the details of each of those home medications that the patient is currently on, and gives me the ability to take one of three actions on each of them. So if I hover over each of these icons, this is going to say continue. So anything that we want the patient to continue, we would say, yep, I'm not responsible for your insulin, so you're going to continue that. I'm not responsible for your lisinopril, so you can go ahead and continue it. And then this ondansetron, if this is one I'm responsible for and I want to continue, stop it, or potentially modify or create a new prescription, we can do that from here. So if I choose to create a new prescription, this is going to give me the ability to modify and or write a new prescription. Let me clear this out though, because I want to show one thing. Reset. In the case that I'm a physician and neither of these two medications, goodness gracious, and neither of these two medications, the insulin and lisinopril, are my responsibility, I can essentially just complete this without acknowledging, or just by acknowledging the remaining home meds that, hey, I've seen them, the patient is on these, but I'm not trying to change them. I'm not trying to tell them to stop, because that's not really something that I prescribe. So we can acknowledge the remaining home meds. So just say that I do acknowledge that those are there. I'm not saying stop or continue, but I want to say continue for the medication that is my responsibility. Here they can see that compliance as well. So still taking not as prescribed, as well as that comment that we entered, taking 3 tabs per dose rather than 2. So the physician can see that during the actual med reconciliation conversation here. And then as far as action buttons go, they have 2 different things. So the reconcile and plan, if they intend to come back to this because they want to do some further investigation, they can plan it. If I've already completed it and I know I'm not going to make any other changes, I can just say sign, and then that would essentially complete my med reconciliation. Before I do that, any questions about what we're seeing on the screen here or what we're accomplishing with this outpatient medication reconciliation? Nothing. Okay, well, I will point out one last thing here. We do still have our plus add button, so this is going to give me the ability during the med reconciliation that if I wanted to either enter any new prescriptions, add any other documented meds, I could certainly do that. So I'm not locked into everything that's on this screen. I can still add additional items if I so choose. So that add button is always there. Well, let me go ahead and sign off on this. I'll hit the sign button. That is essentially completing my outpatient med reconciliation. Everything has been addressed. And then what we get from this, when or if we print the visit instructions for the patient. So here's my ambulatory visit instructions that can be printed. We would see all of those changes, or potentially any changes that we had during the patient's med reconciliation. So we have our ondansetron unchanged because we didn't make any modifications to this. We have our insulin unchanged and our lisinopril unchanged. So these are still the same. We did say that they are stopping the multivitamin because we discontinued that home medication. So stop taking that. And all of these changes are meant to be reflected in this visit instructions in a patient-friendly manner. So all the details that we have written, any changes or additions to essentially their med list would be able to be communicated with them in this manner. questions on this visit instructions, how it's populated, or anything about the med rec conversation? Okay, let me jump back to that home page. We do show both the med history as well as the outpatient rec completed. If I click my view details icon, this is going to show who completed each of those actions. So we can see that med history was last touched or last updated by the nurse role. That's outpatient med reconciliation last touched or last reconciled on this date and time by the physician role. We can still get back to those if we need to make updates. We're not locked in to where it can't be modified or updated, but it is also showing that information. So that's really it. How the process goes from an ambulatory or outpatient perspective. Any questions about the roles that can get to this, or potentially any other interactions on med reconciliation within the system?
Jeff, it's Jeff.
Go ahead, Jess.
Do you want to show like if you're doing a med rec but you don't like the patient maybe not know what it is or like it's not in your formulary?
Oh, yeah, we can certainly show that. So if we have a patient taking something that they're not sure what it is.
Yeah.
Yeah, so if we have that from a med history, even in our documented meds history here, if the patient doesn't know the name of the drug, I think we can do, is it the pill form or is it just the non-formulary that you're wanting to see, Jess?
Just the non-formulary.
Yeah, so if we don't know exactly what the patient is taking or they don't know exactly what they're taking, we can put in a non-formulary med or non-formulary medication so that it's not going to necessarily cause any alerts. But then we can put in the patient's dose, and we can always use the C instructions. So C instructions essentially crosses out all of my dose, route, frequency, duration required fields and allows me to put in taking unknown. I can put depression medication. So we can write that in the special instructions. If we don't want to do that, so we just want to put depression medication, antidepressant medication. We can put that as the drug name, and then that's going to actually fill in for the non-formulary med. So we would actually be able to see non-formulary med, and then in parentheses, we get, oops, close that. We get that drug name that we've written into the drug name field. If they know how frequently they're taking it at least, or anything else like that. We can put as much detail as possible, but essentially showing that we don't have to have the name of the drug. We don't have to have the actual dose route frequency. If the patient doesn't know it, we can always use that non-formulary, and then that will become part of the patient's home meds. So non-formulary med, antidepressant medication, we don't really know the dose route frequency or any of those details, but the patient does know that they are taking it. Other questions or comments? Okay, guys. We have our next meeting, and our next one will be our final iteration because we're not doing any regional working group meetings after, I think, November 20th or 22nd. So Tuesday, November 19th will be our last iteration. Oh, got a couple hands up. Lynn, go ahead.
Sorry, Jeff, it's not a question about MedRec, but and
Oh.
I'm not super familiar with the ambulatory. I'm more lab, but I had a medical secretary in the other day asking about for pre-reg could they have, for a reason, to add follow-up and as like in the drop-down menu, or even make it a default reason for like why they're coming?
For when they're actually scheduling a visit?
Yeah, when they're doing a pre-reg.
Would that be in the reason for visit field?
Yeah, yeah.
I think that is always free text. Let me look at that. So if I'm scheduling an appointment, it's a follow-up, pick my appointment location. Pick my patient. Would it be this reason for visit field?
I think so.
So this is always free text. We don't typically put in drop downs or codified reasons on that field, but I can't give you a rationale. I would probably have to defer that to our scheduling work stream.
Okay. I'll report back to her just to tell her that she's going to have to continue to type it every time.
Yeah, and if you wanted to send me a screen print of where you're seeing that or where she's seeing that, please feel free to do so. I may not be guessing correctly on the reason for visit field.
Okay. Thank you.
You're very welcome. Christina, sorry I skipped you. I just noticing the 1 versus 2, but go ahead.
No, that's totally fine because I have a few people on from Quinty, and we were hoping just to have a bit of your time once you were done with the broader group, to look at a few Quinty specific questions that we had.
Yeah, absolutely. I don't have more items to present. I wanted to make sure the group was aware of our next meeting and that it would be our final, but unless other folks have questions, I can let you guys get about your day, and I can stay on with Christina and team. All right, guys, I appreciate the time. Thank you very much for joining. We'll talk again in a couple weeks.
Thanks. Bye.
Thanks, Jeff.
Thanks, guys.